There we are once more. So if you are anything like any of my patients, 3 miscarriages before proper investigations begin, with the aim of obviously preventing another pregnancy loss at some point down the track is really 3 too many, right? And especially when the vast majority of people who think that they are unable to get pregnant are actually experiencing implantation failure and recurrent miscarriage. And, up to about 50% of miscarriages or implantation failure happens before a woman even knows she's pregnant. So that's even before she's missed a period or even before she's able to detect a positive pregnancy to begin with. So we know that it's a huge, huge issue. And when we're not understanding exactly what the situation or the things are that are getting in the way, that's where we end up getting into more trouble in being able to, of course, stop that going around in circles and eventually running out of time. So as always, I'd love to make this discussion as interactive as possible. So go ahead, let me know where you're watching from. I can see on Instagram, we've got lots and lots of people who have already joined us. So welcome, huge welcome. And I'm Gabriela Rosa. I'm a fertility specialist. I'm also a Harvard University awarded scholar. For the last 2 decades, I have helped couples overcome infertility and miscarriage, even when other treatments have failed. And we have a 78.15% success rate using the fertile method, which is the method that I've developed over the years to help couples in that endeavor. We have now led over 100,000 people in more than 100 countries through many of our educational events and programs. And I've learned a thing or two about the things that make a difference to helping couples take home healthy babies. But in our clinic specifically, we have a very, very big interest in implantation failure, immunological aspects in terms of, keeping a healthy pregnancy to term, and of course, recurrent miscarriage. So this is a topic that is very close to our heart here in the clinic, but also it's something that we know we get some incredible results for our patients with. And I will share more about, the whole purpose of today is so that I can share with you more about how we approach the treatment of these very complex sets of situations and I guess conditions that stop couples from taking home healthy babies when really it shouldn't be happening, or, we should certainly have a much, much more straightforward approach in general in order to resolve this issue. So let me know who is ready. This is the moment. Who's ready to get this started, get this ball rolling? As always, I want to acknowledge you guys. I know how difficult it can be, especially when infertility and miscarriage has been long-standing, for more than 2 years, and lots of things that have been tried haven't worked for whatever reason, or there are things that essentially, you're not quite sure about. And I also know, that the intensity of what it's feeling like to almost get your hopes up a little bit, and think that, oh my God, is there another way? Is there a different approach? Is there something that could help me? And having that almost nervous and anxiety around, well, what if I get disappointed? The reality is you can't get disappointed, because educating yourself is always going to be definitely the path toward getting anything done in life, right? To resolving any problem and solving an issue. And so it takes a lot of guts to be here, but you guys who show up, and some of you show up every week, which is wonderful and warms my heart to be able to connect with you and, really be able to support your journey, even if it is from afar. So I just want to really acknowledge you and know that, you guys, I do this for you, and you're totally in my heart. Right now, you're holding a key. This talk today is a really big deal, and I'll tell you why. These things that I'm going to share with you, most people have no idea about. They struggle through trying to take a healthy pregnancy to term for years without realizing what is actually going on, right? And why. And what happens with those couples many, many times, unfortunately, I sadly see this all the time in my clinic, they go around in circles trying different avenues, things that they think is going to help them, and, trying to figure out how else they're going to get their result without really even understanding what the problem is. And this is what this talk is all about. So this is about you guys almost, you're holding the key, very, very, very golden key, if I say so, because, understanding that these things are even what they are is in the realm of being able to support you with actually further action that's going to hopefully bring a different result. And of course, it takes lots of steps to do that, but certainly we are here for you and we want to see you succeed. So let's get this started. One thing before we do get started, and this is another thing about this talk as well, is I have had a very, very exciting birth this week. Some of you have seen it. Some of you have known it for a little while, but the baby is here. This baby, at least, is here. It has been born. Yay! This too was many years in the making. I will tell you that much. This book is no less than the culmination of the last 20 years of work in this field, in this area, helping couples overcome infertility and miscarriage. And really that's why I ended up calling it what it is, Fertility Breakthrough, overcoming infertility and miscarriage when other treatments have failed. And in this book, and I'll tell a little bit more about the story about, how essentially even this talk came about today, because in this book, in doing the research for it, so about 10 years ago, I identified that there were many different issues, many different areas that impacted miscarriage. And, later it became very, very clear that it wasn't just about miscarriage, it was about implantation as well. But what ended up happening is that about 7 years, or actually probably about 10 years ago, I put together the 7 category reasons for miscarriage, which were essentially a master checklist, a very big, detailed document that I started all that time ago to kind of figure out what are the things that we need to rule out, what are the kind of like places that we need to literally just like have a systematic framework where we go, okay, have we checked this and this and this and this and this? And it started with these 7 categories, right? These 7 category reasons that ultimately, as I was putting together all the content for this book, I realized, hang on a second, there's parts here, there are things that are missing. And there were 2 extra categories that were added in here. So this book I couldn't start this talk without obviously letting you guys know that it's here, but also letting you know that when it comes to implantation failure and miscarriage, there is extra help, there is extra support, and there are things that you can do. So this is certainly, now, every page within this book is part of that strategy. And the reason that I say that, because sometimes people want just like, okay, well, tell me what I need to do. Well, it's actually, in order to change, as I've said before, whatever's going on down here, downstream, which is the result of whatever has happened, we actually need to look all the way upstream to figure out, where are things starting. And so it's no surprise that I'm going to say to you that your strategy for overcoming infertility and miscarriage, and of course implantation failure and miscarriage in this case, is going to be the entire book. However, on pages 47 to 52, I believe it is, let me just, actually I think it's pages 45. From pages 45 to 52, I go through and outline every single one of the categories and give examples and, further kind of detailed information about each one of these categories, which of course I will talk about some of them today. But if you want to get more information, more, advice, and be able to educate yourself further in terms of this is definitely a good addition to your arsenal. And I think that we're still doing a pre-order special, which is, you'll find it on thefertile.me. So that's thefertile.me /book pre-order, all one word. So thefertile.me /book pre-order. And as I said, I will cover this and everything else. I mean, today, always I like to start with what are the questions that we're going to be answering, or some, what are the kind of the topics of discussion that we're going to be talking about today. And as always, I have a list of questions. And these questions, by the way, come from you guys, right? So if there are questions about any of the future topics, which I will talk more about at the end of this talk today, if there are questions about the future topics, feel free to put them under the events, right? I take those questions, but I also know that from having conversations with my own patients, we get lots and lots and lots of questions that people want to know. So the questions of today are things like, what's the difference between implantation failure and miscarriage? What constitutes recurrent miscarriage? Can male factor cause miscarriage? I have recently experienced a miscarriage. What should I do next? Is it possible to overcome implantation failure and or recurrent miscarriage? I'm pregnant now. How can I reduce my chances of miscarriage? Are there any particular tests that should be done in order to be able to get clarity? Is there reduced miscarriage risk if I undergo IVF or ICSI? And what is the reason I'm experiencing these miscarriages? And what else can I do in order to take home a healthy baby? So that's just a compilation of questions. I'm sure that you guys will have more. By all means, make sure that you write it down on the chat. I always prefer, because the timeline on Instagram goes really, really fast. You can certainly type questions in there, but I might miss it. Let me see if I can. Oh, I can actually go backwards. Oh, look at that. Learned something new today. So yes, I can go backwards and find some, I think. So hello. For those of you saying hello, it's wonderful to have all of you here. And Anu, great, wonderful to know you've purchased the book. I can't wait to sign it. In fact, yesterday I was looking at this and all the people that I'm signing books for. I think I'm going to be very busy over this weekend signing lots, and there's hundreds already that I have to sign, and I look forward to writing all the beautiful messages that you guys have requested and some of my own as well. So that's going to be super, super cool. But let's get straight into it. I think that one of the biggest things that people get confused about is what are the definitions. So I always like to start with a couple of little definitions so that, unfortunately, somebody's asking if the book is available in Spanish. If you can find me an editor that's willing to buy the rights, yes, it will be. And I'm happy to sell it very cheap. So, actually, Spanish is one of the things that I do want. So I'll put this out there as well. 3 languages that I would like to get this book published in the next, say, 12 to 18 months are Arabic, Spanish, and Portuguese. So if you are listening to this and you know of someone who knows someone who knows someone, or you know that you are an editor and you'd like to discuss the rights of this book in those languages or even in any other languages, let us know, because definitely our team and the publisher is looking to make those connections in the next 12 to 18 months. So we want to get this into as many languages, translated into as many languages as possible. It's a wonderful book, and I know that it will help many, many people around the world. So if you know someone, get in touch with me. You can get in touch with me directly. All right, just by private message is perfectly fine. But anyway, so as I was saying, let's talk about the definitions, and let's talk about, implantation failure. Let's talk about miscarriage. Let's talk about stillbirth. So a couple of things you need to know. Implantation failure. The official definition is that you need to have had 3 failed IVF attempts with good quality embryos. Okay, that's the basic current scientific definition of implantation failure. And this is, where you read in journals like Fertility, Sterility, and Human Reproduction, and so on and so forth. There's a push at the moment for enhancing that definition and increasing the number of IVF cycles that are required in order to actually proclaim that diagnosis. I have a problem with that, but I'll talk about that at another day, at another time. However, the push currently is that failure of a clinical pregnancy, and mind you, this is not about taking home a healthy baby, so there could still be placentation issues leading to pregnancy loss that are very closely related to that kind of implantation stage. But again, this is kind of more broad and general science, sometimes is not exactly categorical about many things. And this is one of those things at this point. But basically, failure of a clinical pregnancy after 4 good embryo transfers and at least 3 fresh or frozen cycle in a woman under the age of 40. Okay, so those are the kind of floating definitions in the scientific world and the kind of difference that you get, depending on who you read. However, I'll say this, my definition of implantation failure actually also must include and expand into natural conception, okay? Because here's the thing. If you have fallopian tubes and they're patent, okay, they're clear, and sperm can swim through. If you've had tests and have been told that your fallopian tubes are clear, then that is essentially a tick right there, right? So if you have fallopian tubes that are patent, if you have sperm, right, and you have egg and ovulation, and you've been trying to conceive for over 12 months, either naturally or in any other way, but let's talk about naturally for now, right? Really, I think that we then need to start thinking about and talking about the expansion of that definition, looking at this, because here's what happens. The reality of it is that, as I said earlier today, about 50% of pregnancies end in miscarriage, right? And this is even before a woman knows she's pregnant. So what is possible for many people in this particular situation is that they're actually getting pregnant, but they're not able to keep a pregnancy to term. Therefore, the idea of, is this infertility or is this miscarriage almost kind of blends together, so to speak, right? And we need to be able to take that into consideration when we are really discussing and talking about what are we actually dealing with, right? Because one of the biggest things that I see, one of the biggest issues that I have come across, and certainly that I am very aware of that happens for our patients, is the reality that not enough investigations go on in order to really be able to understand what is getting in the way for a couple, not only in keeping a pregnancy to term, but also trying to conceive. So we need to be able to ascertain what's going on there. So my definition of implantation failure would have to expand into taking those things into consideration as well, okay? Miscarriage, basically recurrent miscarriage is defined as having had 3 miscarriages around the world. We treat patients, obviously, as many of you know, we leverage telemedicine. We treat patients from all over the world. And so what that means is that the majority of times when we're talking about this conversation, we're talking about losses, at least three pregnancy losses over however long, right, but consecutive. And so, for example, if you have been trying to conceive and you've had one pregnancy and that ended in a miscarriage, and then you had another pregnancy that was taken to term, and then you've had another 2 pregnancies, that's no longer considered recurrent miscarriage. Beg your pardon, 2 other miscarriages. That is no longer considered recurrent miscarriage. Okay, so it's almost like the clock starts again. And so basically what ends up happening is that without us really understanding, without us realizing and noticing that, hang on a second, how is this actually impacting what's going on? We start to not realize that we need to be doing more, right? We need to be actually implementing a much more rigorous way of looking at this situation than perhaps has been implemented previously. Okay, so recurrent miscarriage, even like for me, again, personally, and I look at this not just from the perspective of being a woman, but also from the perspective of the types of patients that we see. And I'll be the first to admit, the patients that we see in my clinic are different to the general population, right? The patients that we see in my clinic, they typically have tried, they usually have been trying to conceive for 2 years or more, have experienced 1 or more miscarriages, typically have done many different types of treatments that have not had any success, have more than one known obstacle to optimum fertility. And we know obstacles, minor factors, essentially we know from epidemiological research that if we add a couple at peak fertility has an average of 3 months time to pregnancy. So literally it's have sex, get pregnant, have a baby, no longer having this conversation. When we're still having this conversation, epidemiology tells us that there are things that we need to start looking at, right? We know, again, from data that is, gathered and put together from around the world, that essentially when we're looking at that, one minor factor is enough to give us an average of 2 years, from 3 months to 2 years average time to pregnancy. A second minor factor would basically give us an average of from 2 to 7 years times to pregnancy. And a third minor factor gives us an average of 40 years average time to pregnancy. No one has that time to get pregnant, right? And again, if we're looking at, and many times I'll talk to people and they'll tell me, but my problem's not getting pregnant. Well, actually, I can get pregnant, but I have miscarriages. Again, that definition blends a little bit. You know, once we've had recurrent miscarriage and recurrent pregnancy loss, it's almost like everything gets bundled in one place, right? And so, but ultimately, those are the kind of like standard definitions. You know, 3 consecutive miscarriages would then lead us to the diagnosis of recurrent miscarriage. However, as I was saying previously, in my clinic, if you've had 3 miscarriages, and even if they weren't consecutive, given everything else that I know about you, we are going to be testing much more in depth and much more detailed than we would in any other clinic around the world. And again, I know this because we have access to patients from around the world that have gone through multiple different types of protocols and testing. And it's really bizarre. Like when, you know, and I'll mention this in a moment, but it's about 2%. What we see in our clinic, about less than 2% actually, of people who come to us who have been told that they have been previously thoroughly investigated actually have, right? Less than 2%. So it's a huge missed opportunity for couples who have been struggling to conceive for a very long period of time and or take home a healthy baby. So that's recurrent miscarriage. Miscarriage itself is classified as a pregnancy loss that happens before 20 weeks. Any pregnancy loss after 20 weeks is then categorized as a stillbirth. And, you know, I mean, any of it is completely traumatizing. And, you know, if you've gone through I've spoken to a lady this week who was talking to me about how difficult her and how traumatized she was for a miscarriage that she had that took 6 months to resolve. She had to have multiple surgeries, you know, things, her HCG was still not coming down. So, you know, it can be incredibly traumatic. And just as well, we don't find out about many of the miscarriages or pregnancy losses that we, you know, probably would have in our lifetime when trying to conceive, especially for an extended period of time. So my purpose today is really, you know, to answer as many questions as you have, which we've talked about before, kind of in that realm, but to really share with you 3 big ideas, right? I want to definitely go through and help you understand the different categories that we look at when we're testing, but we're going to go through 3 big ideas, and you guys can ask your questions and let me know exactly what it is that that you want to know. But yeah. And I can see here, you know, in the comments, yeah, I think you guys agree with me, right? Where 3 miscarriages, I mean, let's be honest. Who wants to go through 1, let alone 3, before you start being taken seriously, or before you start being told, oh, actually, maybe this is something that we should investigate, right? Anybody? Of course not, right? Let me know below if you want to actually be able to prevent, you want to really screen enough so as to even prevent a miscarriage when already you've been trying to conceive for more than 12 months. I mean, that to me makes total sense, right? And again, it doesn't make sense across the general population, definitely not. But certainly in our practice and the types of patients that we treat, that absolutely makes sense. And really any patient that has been trying for more than 2 years, it absolutely 100% makes sense, right? And I can see you guys, like, you know, commenting and on Instagram and Facebook agreeing with that, because yeah, I mean, nobody wants to go through that. So let's talk about big idea number 1, right? Big idea number 1 is that taking home a healthy baby is a result, and let me repeat, a result of many biochemical processes, right? This is something that I cannot overemphasize. When it comes to creating an outcome of a healthy baby, imagine there are millions of biochemical processes that the body goes through just literally in order for me to be able to be here, standing up, talking to you. Imagine what it needs to do in order to create a healthy pregnancy to term, right, over a 9-month period. It is a feat. I mean, just the fact that, you know, there are people in this world is incredible, right? The miracle of life is indeed a miracle. It's like the absolute best chance that a couple has at peak fertility of getting pregnant is 20% in any given cycle, right? So if you look at 20% in the general, you know, kind of grand scheme of things, it's incredible that any of us have made it, you know, this far. And then when you look at it, that the majority of babies, you know, I mean, obviously majority of pregnancies don't make it to term, or at least 50% don't make it to term. Then you look at, you know, the fact that the majority of babies or children who die die under the age of 3, then another big chunk die under the age of 5. You know, just to be able to actually be here is such a privilege, right? So looking at all of that in context, one thing that we need to be very, very clear about is that when you see that you've experienced a miscarriage, or that you are told that, you know, you have a problem that you need to address in terms of your fertility, okay, what you're dealing with is just news about something that you can no longer do anything about. It's the news of a result, of an outcome of previous things that had been done up until that point, okay? And mind you, it's not necessarily always that you're the one doing the thing, right? So please, and this is one thing that I want to make sure that I absolutely confront face on, right? You having a miscarriage, you having difficulty conceiving is not your fault, right? It is just not your fault. There are things that you absolutely can do to improve your chances, to increase the odds, to help nature do what it does best, to help assisted reproductive technology do what it does best, right? But let's quit this whole idea that if you've had a miscarriage, if you've experienced a stillbirth, if you have all traumatizing life events, absolutely, and none of it your fault. Right. And I want to make sure that people are really, 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 really clear about this, right? Really clear. And I mean that because I often hear people, and people get very, very triggered, you know, like in the Fertility Challenge, as you guys know, many of you do know, if you don't know, you'll know now. We run the Fertility Challenge. We've now had literally hundreds of thousands of people go through that event. And in fact, the next one's coming up in October, at the end of October. It's a wonderful, free, full-on 12 days of education where I'm there just, you know, really supporting you and guiding you through many different tasks and some other things. If you haven't done it before, do it, and then you'll know. There's lots of great prizes too. But anyway, in the Fertility Challenge, one of the things that we often get to field and people get really upset about, because I'm all about taking charge, right? Like if you know anything about me, and if you don't know, well, now you do. I absolutely believe that there are things that you would never be able to do anything about, right? And those are the things that, sure, leave it to God. Right? Leave it to God to determine, to do whatever it is that, you know, God, well, whoever is your God as well, by the way. Like, I'm not a religious person, so, you know, but ultimately, whoever's your God, leave it to God to do whatever it is that God does. The main thing about everything else in life, and even when it comes to God, my belief, right, and this is just my belief, you can completely disagree with me on this, but that's kind of how I roll, and that will give you context as to how I give recommendations, right? Because the way that I believe, my belief tells me that in order for God, whoever your God is, to help you, you need to help yourself. So I truly believe that God helps those who help themselves, right? Do your part and the heavens will come to your aid. How many times I hear couples say, you know, either because they've experienced infertility for long periods of time or have experienced miscarriages, it's God's will. No, you know what? It's not God's will. God's will is for you to educate yourself. God's will is for you to actually become better and improve and understand the places where you actually have some utterance of control and some kind of, you know, resemblance of being able to take charge and do what it is that you can do to improve your lot in life, so to speak, and the places where you just need to accept that you've done all that it is that you can do, right? That's where I come from. If you don't like it, if you disagree, that's fine. But that's just so that you understand that I don't believe in like taking blame, and I don't believe in pointing and giving blame, right? I believe in doing my very best. That's what I believe in. That, honestly, that's my religion, right? Do my best so that I can help other people do their best. And as long as we're all doing our best, I think that the world can be a much better place. And this is literally a conversation that is so important to have when we're talking about fertility and when we're talking about miscarriage and when we're talking about implantation failure. Because guess what? If you don't do your best, the things that are now scientifically proven, I mean, this book, there's over 500 references in this book from scientific journals, right? Talking about and validating every single one of these things that I talk about. Because what? Guess what? that's what I know has worked for our patients, and that's what continues to work for almost 80% of the people who go through our signature program. So I know for a fact that there is more that you can do. You'll see the stories. There are stories in here of our patients. In fact, this beautiful baby is one of our babies, and her story is in here as well. But these babies would have never been here if it wasn't for these patients, these couples taking charge. Right? So make no mistake, I'm not going to be the practitioner or the person who's going to tell you that, there's nothing to do. Sure, just, sit there and hope for the best. And, it's a numbers game. Yeah, as much as it is a numbers game, there are things that you can do. Therefore, do those things, right? Do those things, and do those things for as long as it takes, because that chain reaction that is the results that you're experiencing in your life right now until you do. Right? It's as simple as that. And that really is what it comes down to. Some people won't like that idea. Some people won't like that message. Some people will think that I'm just, way too over the top. That's fine. Clearly you're not my people, and I love you for that anyway. Right? But the reality is that there is a person, there are some people listening to this right now who really need to just understand. And yes, it's you. Right? If you're still here, who really needs to understand that there is more that you can do and that only you can do. Right? So don't just sit around and wait and hope and pray that, this is going to change until you do. Fertility is a team sport. There is no two ways about it. Right? If you're looking, and when we're talking about, I say fertility, obviously we're talking about implantation failure and miscarriage. A third of the reason as to why a miscarriage happens is to do with male factor. A third of the reason is to do with female factor. And a third is to do with couple factors. So make no mistake about it. Both of you have a role to play when it comes to fertility, when it comes to keeping a healthy pregnancy to term. Miscarriages don't happen for no reason. There are always going to be reasons, and those reasons are definitely going to play a part when we look at it from the light of those three different, places: male factors, female factors, couple factors, right? So that, and of course, then obviously you have even the embryonic factor when it comes to the other side of this, because the embryo will also self-determine. Believe it or not, we're understanding more and more through science that whatever happens, that the embryo has also its own say in the biochemistry and the changes that occur and what happens through that entire process. So this is something to really take into consideration. And then, of course, removing the obstacles that are getting in the way. If you drink too much, if you smoke, if you do drugs, if you know that there are specific chemicals and toxicants and, specific health conditions that need to be improved or optimized or addressed, whatever it is, those factors are obstacles. Believe it or not, they are obstacles to your result. They are obstacles to the chain reaction that we're talking about that is a healthy pregnancy to term. I know that it sounds really kind of like hands off, like a baby is such a personal thing and it's such a love bond situation. But guess what? Before we get to that, we need to get through biochemistry. We need to get through biology. Right? And if we don't get through biology, we're never going to have the other side of that. Is this making sense? I'd love for you guys just to, give me some love, give me some likes. Let me know in the comments. Let me know in the comments on Instagram. Is this making sense? Right? Because that big idea, the big idea that this is a chain reaction, that this is already in the past, is a really important idea to understand that you can only change it by beginning now. Okay? And that is a key, crucial piece of understanding. Because what ends up happening a lot of the time is that people get pregnant and then in retrospect they think, oh my God, I want to do everything that I can to prevent another miscarriage from occurring. No, that's not when you prevent another pregnancy or another miscarriage or pregnancy loss from occurring. Right? You prevent miscarriage and you prevent pregnancy loss from occurring by actually being proactive. And that is a crucial piece of understanding. Remember, I talked about egg quality recently, and one of the things that I talked about is the fact that it takes 8 months for the egg to mature. 8 months, right? This is not me making this up. This is biology. There are 2 cycles of approximately 4 months each, from primordial follicle to primary follicle, from primary follicle to ovulatory follicle, 4 months each. That's an 8-month lead up to just having an egg be ovulated, right? Sure, those eggs are constantly getting recruited and they all kind of start, and that's essentially how AMH gets measured incorrectly. So if you want to understand more about that, go and listen to the egg quality webinar. But basically, all of those factors will make a huge difference when we're talking about that initial cell that is going to end up giving us the outcome that we're looking for or not. Okay, so we couple those 2 cells, and this is why I talk about whenever you have heard me say or hear me say, or if you're hearing me say this for the first time now, if you want to change a reproductive outcome, whether it's miscarriage, implantation failure, infertility, whatever it is, right? The way to do it is to act pregnant now to get pregnant later, to get pregnant and take home a baby later. Because right now within you, you already have half of that little baby that you're wanting to create. And that applies to both of you, both prospective parents. So what happens is the men have just as much a responsibility to nurture that cell that is going to create that healthy baby in the same way that a woman has, even though the woman has the even greater responsibility of nurturing that embryo for a 9-month period and obviously beyond, right? But the truth of it is that we can't move this forward without those 2 cells. We are not asexually reproductive beings, right? And so therefore, we need to really be able to take into consideration everything that goes into this mix, into this cauldron, if you like, right, of the result that we're experiencing, okay? So like everything in life, there's an action, there's a reaction, right? So we need to be proactive, we need to be deliberate, we need to be attentive to the things that we are doing today that will have an impact in our tomorrow. And infertility, miscarriage is no different, right? But again, this is nothing to do with blame. This is about making the best possible choices that we can, knowing that we are going to falter, that we are human, that it's not going to be perfect. And in fact, this is the one thing that I never expect from my patients. I expect that they will absolutely all do their best. And in fact, I know many of my patients listen to this, and they will be the first to tell you that, yes, she is hardcore, and yes, she expects that we do our best, right? But I don't expect that you'll be perfect, because I'm not perfect. I've never been perfect. I never will be perfect. In fact, I am probably one of the most imperfect beings ever, right? But the truth of it is this: I do my best, and sometimes my best is better than other days. There are days where I feel great and my best is better than another day when I don't feel great. And this applies to everybody. So the key here in big idea number 1 is looking at the fact that, yes, it is retrospective. Yes, it is something that we need to look at in much more depth, but it's something that you can do, and it's something that you need to do if you are to change your results. Okay. So that's very important. Now, big idea number 2 is that there is no way, right, of knowing what your obstacles that you need to overcome until you actually first identify them. Right. And I know this sounds so absolutely ridiculously basic, right? But this is a big idea for a reason. Remember, we treat thousands of patients every year. We know that, and we screen even many, 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 many more, right? And when we screen a couple to figure out if we can help, because we only take on patients on board of the Natural Fertility Breakthrough Program if we believe that we can be of assistance. And so what happens is, when I'm screening, I screen thousands more people than we actually take on board, right, of the program. I see, and I know this to be true, and I know this for sure, that the patients that come into the clinic, that come into the program, and this is not even like the number would be much, much less than this for the patients who don't, right? But no more than 2% of cases of people who are told, they were previously told that they were properly screened for implantation failure and miscarriage, actually have been, right? So I know that there's a lot when it comes to implantation failure and miscarriage. There is so much that gets left to chance. There is so much that gets left on the table. I've been researching this topic for many, many years, more than 10 years, certainly, and obviously doing this work for 20 years. So I know for a fact that there is so much more that needs to be taken into consideration when it comes to this whole question of implantation failure and miscarriage, that it doesn't. So what I want to do is I want to actually go through these main reasons, these main categories, right? So that you guys can really start to understand more about some of the areas. The one thing that I will say though is this: for each one of the categories, the categories act almost like a giant label, right? So it's a giant label that I place to be able to go, okay, this is a place, an area that we need to address. This is an area that we need to look out for and look at. Then there are, of course, under each one of those areas, there are several, if not several specific things, but sometimes several dozen points that need to be looked at in order to be able to ascertain and understand what are we actually dealing with, right? So literally we have like a massive major checklist that we go back to make sure that we really have, like Atuga Wandi, Harvard professor and an amazing writer, actually. He wrote a book called the Checklist Manifesto. And it's basically what he's used in his research, but also at Harvard, they use this in many of the Harvard hospitals, but also in many countries, many developing countries have now implemented this. And it's something that he's borrowed from the aviation industry, where basically in the aviation industry, what happens? A pilot does not leave the ground without going through checklists, right? And the checklists are in big folders, and the co-pilot basically calls them out, they check it together, and they make sure that everything is how it needs to be. Atuga Wandi brought that into medicine, right? And he started doing this in surgery. And what was really fascinating is that when I first picked up that book, actually when it was published many, many years back, I started to do exactly that. So I've created now checklists for literally every possible thing that you can imagine, that to do with this particular, area and field of interest that we have. So we have very extensive checklists on every particular thing. But this is one that I would never, just to imagine, to consider doing this work without that checklist gives me goosebumps, right? Because guess what? Nobody is going to ever be able to remember all of these things. So we just keep adding. Right? We just keep adding to our testing protocol. We just keep adding to all the checklists that we've got once new information comes, to the fore. When, we've discovered something that through treating patients is one of the most amazing and incredible things, because all of a sudden you put things together and you join dots that you never even knew existed. Right. And that is very much part of how a lot of this, a lot of the concepts and really what you read in this book is very much that compilation of, what is the best of the best that I know will help to move the needle for couples in this particular situation. Right. So definitely that's something that I would highly recommend. But we want to make sure that this is very clear, because again, it's very easy to be told, oh yeah, no, everything is fine. Everything is fine. Just keep trying. How many of you have heard that? Right? I'd love to get on the comments. How many of you have heard everything is fine, just keep trying? Just put yes on the thread, just so that I know, yes me, or yes I have, or something. I'd love to see how many of you, and even if you listen to this afterwards, yeah. See, already on Instagram, like, yes. Because this is something that gets told to people all the time. But let's look at this objectively, right? If everything is fine, then doesn't that equate? Yeah, look at all the people on Instagram just going, yes, 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 yes. Yeah, right? If everything is fine, right, just keep trying, then why is it that after years of trying, we still don't have a baby? Right? Because really, if it's fine, then this should be a moot point altogether. right? And I know that, when you look at it from that perspective, it's like, oh, but that's simplistic. Well, sometimes things are that simplistic. Sometimes it's actually about looking at what evidence does life demonstrate, and therefore, what else do we need to do? Because unless we look at it from that point or from that place, well, we're going to, again, continue going around in circles, right? And we don't want to do that. So, and because in my clinic, we specialize in difficult and complex cases, like these things don't happen overnight. That's why we have to be so diligent and making sure that we are looking at and addressing every possible thing so that we leave no stone unturned and nothing to chance. So let's talk about these 9 categories. I'm going to just run through, first of all, what they are. Right. And there's going to be a little bit of overlap, and as I was putting this together, and even as I was reviewing it for this talk, I thought, but these things are kind of similar. How can I explain it better? And you know what? Like, I'm never done with this work. That is one thing that I can tell you. So, sometimes I just have to put things down on paper and deliver them as they are. And then I'll come back to them and I'll fine tune and tweak. And in 2 years' time, I'll do an updated version of this book. And guess what? I'm going to actually probably come up with a better version, right, than what we have now. But ultimately, right now, this is what we have, and I'll explain the nuances and the variations, and then we can take it from there. But basically, categories as they are and as they appear, there's no order of importance here, right? There's just an order of appearance because, right? But endocrine imbalances, so that's hormonal imbalances. And I'll come back and I'll talk about some of these things. Obviously, I'm also aware of time, so I'll come back and talk about some of them. But like I said, pages 45 to 52, I think that I said earlier, pages 45 to 52, I go in depth in this book. I go in depth about that. So you feel free to grab yourself a copy and check it out for yourself. Endocrine imbalances, hormonal imbalances, okay? Anatomical factors. So these are to do more with fibroids and placental abruptions and umbilical cord issues, things that happen to the anatomy of that area in a way that stops a pregnancy from from occurring. But that's related to both embryo or fetus as well as the prospective carrier. Okay. Then there's uterine defects, which is specifically related to the reproductive carrier. Okay. So then, and I'll talk more about what can happen there. Infections is another very big aspect. And infections is different in this particular consideration to immunological aspects that relate to autoimmunity and alloimmunity. Okay. And again, we'll come back and talk about that. Then there's genetic factors. That's category 6. Then there are male factors specifically. Then there are reproductive toxins in 8 and 9, unexplained or idiosyncratic factors. And again, we'll come back and we'll circle back. But you can see that there are many different areas. Let's start back on the top and let's talk about endocrine and hormonal. Obviously, those are to do with your reproductive and also metabolic hormones. Reproductive hormones are all of your, your FSH, your AMH, your LH, your prolactin, you name it. All of the hormones that basically make the egg mature and the sperm forming and, all of the things that are basically going to help estrogen, all the hormones that are going to help with carrying not only that cell to a mature stage where it can actually affect a pregnancy and or become a pregnancy, but also then obviously the development and the maturation of that embryo. Okay, so those are your reproductive hormones. Then we're looking at metabolic hormones from thyroid function, which is very, very linked with reproductive function. Thyroid, if the thyroid is not working effectively, and in fact, I do a whole piece in the book about that, and also in the Fertility Challenge, if thyroid is not working properly, we are going to end up with an increased risk of miscarriage. But also, you see, that's where thyroid, hormonal imbalances in terms of thyroid kind of almost overlap in different categories, because that's also to do with autoimmunity in some cases. So you can see that there are some crossover links between these different categories. And that's why it's important when we do this work for our patients, we actually look at correlating every single aspect of what's going on for them. Because if we just were to be very categorical and to look at, are we addressing these categories and not looking at what kinds of effects they can have? So for example, let me just put it this way for you, and this will give you an example that will make sense. the thyroid is extremely important to carrying a healthy pregnancy to term. If there is an imbalance in thyroid hormones, particularly in TSH, what's going to happen is that it's going to have, it essentially means that the thyroid isn't working properly, it's underactive, and that metabolic function is also underactive. Typically, body temperatures are low. Cells can't reproduce in low temperatures. So if that's happening, then obviously the embryo is not going to be able to develop in the way that it needs to, and miscarriages are more likely. So that's one of the ways in which that can occur. There are other metabolic pathways that will also, with the same problem, create a pregnancy loss. But that's just to give you a bit of an overview and an example, okay? So what happens with that is this. If your TSH is normal, but your thyroid antibodies are abnormal, and we know that there is an immunological aspect, it's possible that you've just picked a good time of the day to have that test done. And it was, TSH was under the kind of normal range because basically it was a lucky day, okay? But it was actually unlucky because if we have elevated thyroid antibodies, we know that very likely that's going to impact the thyroid, and it can make it overactive or underactive. But typically it will make it underactive first or for prolonged periods. And what ends up happening is that if we pick that up, then if you only test, and this is part of the problem, when somebody has a miscarriage and they're tested for TSH, and on that day, let's say, your TSH is actually low or below the range, which the range is ridiculously high, by the way. It's like from 1 to 4 is the range, and anything above 2.5 is, and that's international units per milliliter. Anything below 2.5 is ideal, but really we like to see it in our clinic. We like to see it at around 1, okay? So really 2.5 is already overboard as far as I'm concerned, especially if somebody is having recurrent miscarriages, okay? So those are all things that we need to take into consideration. But basically, let's say, for example, that in that case, that person has elevated thyroid antibodies, but it hasn't been checked because it normally doesn't get checked. They've experienced miscarriages in the past, and their TSH so happens to be normal on that day. So do we have a thyroid problem that's affecting miscarriage in this case? No, not on paper, right? But if we only test once, if we only test one thing, if we don't actually are very comprehensive about everything else that we're looking at, then of course we're going to miss it, right? And that is essentially what happens very frequently. Most testing gets done. Sometimes it gets done and it's not correlated properly, and it's not done in conjunction with a full picture. So things get missed. Right? And that is why, I'm so pedantic, and I'm completely pedantic when it comes to this, and having these, areas properly correlated and organized, and I'm constantly, we have an amazing clinical director, and we have her for this very reason, which is basically to ensure that every single one of these things are checked and double checked and triple checked, because otherwise, these things can get lost, right? And then we don't end up with the results that we want. Okay. And we can see the hormonal plays a big role, but it's also there are other links, right? And so that's important to consider here as well. Anatomical factors, like I said, that these can be things that are to do with just the gestational carrier, but also to do with the interaction between fetus and gestational carrier. And I say, obviously, mum is the word here, but some people go through this journey differently. Some people do have a gestational carrier, and some people, because they need a surrogate, and some people need other things. And so, but basically, placental abruption, umbilical cord issues, those are some examples of things that can go wrong there. I know that very soon Instagram is going to boot me out, so you guys need to jump on Facebook if you want to continue this. I will do my very best to still, give you as much as I can in the time that we have. But like I said, if for whatever reason it's not enough, go to the book, because the book has got all of this and more. Uterine defects are also really important. So here there's congenital abnormalities. So the defects that we're born with, but also, these are things that, could be a misshaped uterus, for example, a bicornate uterus or a unicornate uterus. Those things will definitely make a difference. There's a septum in a uterus, like sometimes these have to be fixed or, addressed by surgery. But basically, congenital abnormalities in terms of uterine defects are definitely parts is something to be ruled out when it comes to actually carrying a healthy pregnancy to term, and recurrent miscarriage for sure. Then there's acquired anomalies. So things like adhesions or cervical trauma or cervical insufficiency or incompetence that causes miscarriages. All of those things are important to take into consideration. Infections, sexually transmitted infections are a huge reason for recurrent miscarriage because they're usually silent. Right? There are no symptoms. So testing for chlamydia and E. coli even that can overgrow from the bowel. If there's an overgrowth of E. coli in the vagina, that can certainly cause problems. And even in the sperm can cause problems for those cells as well. Gardnerella, gonorrhea, group B strep, mycoplasma, ureaplasma, all of those things are things that we want to rule out. Then, of course, there's just generally acquired infections that will also negatively impact fertility. Cytomegalovirus, herpes simplex should also have been in the sexually transmitted. But things like even the flu, Lyme disease will cause an issue here. Rubella, toxoplasmosis, the Zika virus these days. So all of these things, again, and these are just examples, right? I'm going through some examples for you to be able to understand the scope in which we want to be playing around. But certainly it's not how do we say, it's not exhaustive in this conversation because obviously we don't have a lot of time. Then there are immunological aspects, and this is talked about a lot. In fact, I'm doing a whole Ask Gabriela Rosa on natural killer cells, right? Because that's an important, and alloimmunity as well. I'm devoting entire hours to these topics because they are so important, okay? And we'll be announcing at the end of today, I think, or by tomorrow at the latest, we will be announcing the next month's talks so that you guys can also kind of pencil that into your diaries. But, specific antibodies will also cause a problem here. So things like cardiolipin antibodies, anti-lupus, anticoagulant antibodies, or ANA, anti-ANA basically is going to cause extra clotting. You've got the whole thyroid antibodies situation. The cardiolipin also causes extra clotting, and that coupled with things like MTHFR, for example, can be really problematic, which obviously happens in the genetic side of things. But really what we're looking at there is we're looking at where do these things kind of cross over, right? And if we already have a predisposition, for example, to clotting because of MTHFR, and then we don't find out or we don't screen properly that we have a thrombophilia of some kind, then, what else are we dealing with that we don't know? And what else could be getting in the way that we do need to be addressing? And again, those are the genetic factors. But coming back to the immunological, alloimmunity is also something to be taken into consideration. So if a woman has been pregnant before, she might have developed a reaction to the antigens within the embryo. That can also be problematic if the RH from a man and a woman is different. If a woman has a negative RH, which typically is positive, and a man, they're different, then obviously it's going to be a problem as well in terms of alloimmunity and keeping a pregnancy to term. Of course, there are things that can be done about these things. An anti-D injection for women who have partners with a different RH is definitely going to be important if the woman is negative, right? If the woman's positive and the man's negative, not so much of an issue, but if the woman's negative, definitely an issue. And that's something to take into consideration. In fact, both of those cases are things to be looking further into, absolutely. But, and for some people, some people never found out that was the case and they were born. But for these days that we know and we understand, obviously we want to make sure that we're putting in place all of the things that we can to optimize chances. I know that Instagram, I've got a 2-minute warning on Instagram, so you guys will need to jump on Facebook if you want to continue the end of this talk. Then, of course, the genetic factors, as I mentioned, there's various SNPs. In fact, last week, unfortunately, we had terrible internet connection and the MTHFR talk did not get recorded. And so I will be redoing that talk. But I talked about this last week and various SNPs, and MTHFR is one of them. But ultimately, it's an example. Most people have heard about it. You know what I mean. Out of the inherited and acquired thrombophilias, we've got factor V Leiden, and of course, the antibodies that I've talked about as well can also overlap into the immunological aspects that we were talking about. And then, of course, there are male factors. And male factors, make no mistake, male sperm will impact the ability to keep a healthy pregnancy to term. If you want to know more about that, listen to my egg quality talk And, you know, just know, I mean, I will put references that as part of these events. What's happening is that we're having them all catalogued for you. And so with the catalogues, we're actually putting some scientific references for you to review, okay, and for you to have a look at in terms of these things that I'm mentioning, because sometimes we just don't have enough time to talk about everything. As I said before, you know, an hour goes too fast. And so I'm doing my best to just compile this information for you so that you can have further access to it and you can, you know, have a review of it later down the track. But that's going to be, I'll make this available probably by the next time that, you know, next week's talk, it will probably be available by then. Then, of course, reproductive toxicants. And these are things like heavy metals and pesticides and herbicides, phthalates, plastics, you know, you name it. Gosh, there are so many different things in terms of this that we need to take into consideration. And of course, you know, like non-stick stuff, you know, like all your per and polyfluoroalkyl compounds, which make all of the non-stick things, you know, all of that is scientifically proven to cause miscarriage or increase the risk of miscarriage. Air pollutants, you know, lots of different types of toxicants that in a science, like if you look for journal articles on these things, you will find the link between miscarriage and all of these factors. And part of the reason as to why I talk about all of this in the Fertility Challenge, if you have not yet done the Fertility Challenge, I highly recommend it. It's going to be highly enlightening to know many of the things that you can change, or you can speed your process up and get a book because that's definitely going to also talk about all of those of the things that I talk about in the challenge, plus a whole lot more. Okay. So, and then of course there are the unexplained factors or the idiosyncratic factors. You know, the lack of a systematic and methodical investigative rigor typically is one of the biggest issues here, because I don't believe there is something as, you know, there are things that are unexplained. There are things that people either have not yet been able to explain because they haven't put enough time and energy into or focus into being able to explain it, or we just don't yet know enough. And that's okay, because ultimately we might know that we might have, how do you call it, clues along the way, and we might need to find more information, but unexplained is big, right, as far as I'm concerned. So there are miscellaneous factors too. There are kind of overlinked areas, you know, nutritional deficiencies, lifestyle factors, combined couple factors, you know, all of these things kind of fall into this more miscellaneous area. But this is also it's an area, it's a category that I'm actually spending time to sort out. Right? Because, and this is an ongoing process in our clinic, by the way. This is an ongoing piece of work because it never ends. You know, we're constantly finding out more, understanding where we need to place different things, how they actually work together. And so, you know, all of this will make a difference in the end result for our patients. And that's why we do it ultimately. But understanding that there is always going to be more to look at is also important, because we can't think that if you feel like you've tried everything and nothing has worked, is because you've actually hit the ceiling of what you knew you could do, right, on your own, or with the support that you've had in the past. So basically, it's never true when people say to me, you know, and this is big idea number 3, really, it's never true when people say I've done everything, nothing has worked. Not true. We might feel that way. We feel like it's true, but it's actually not. What has happened there is that we just have run out of things that we know we can try, right? Of the things that we can actually feel like there is a plausible explanation for us to give it the effort and the time and the focus that it requires. But it's never to do with, you know, like I've tried everything, nothing has worked. Also, when people say that, you know, you're not keeping a pregnancy to term, go to IVF and let's have PGS testing and let's do some extra things that, you know, we can do and see if that will improve things. The vast majority, the vast reality of this situation is that unless you have addressed all the other obstacles to optimal fertility and you have looked and combed through every single one of those 9 category reasons for miscarriage or implantation failure, it's very likely, very possible that IVF will still fail anyway. Okay. So that's what I say to people. who ask me, should I do this or should I go to IVF? It's like, no, it's not one or the other. You might still need IVF, sure, but this is essential. This is like the foundational work that you need to do, because if you don't do this, then guess what? You're going to leave so much to not only chance, but to complete oblivion that could really help you understand further what it is that needs to happen for you to get a result, right? So that is crucial, absolutely key. Definitely no questions asked in terms of it's never one or the other, right? You may still need IVF, but you need this before you even embark upon something that hasn't actually looked at every aspect of what's going on for you. So, that is a very important clue, okay, to think about and to look at. Now, in terms of the reason as to why this is so important, I see two very different stories in my clinic. And, there's things in between too, but the two big stories that I see are the happy and the sad experiences. The happy experiences are the ones where people investigate, they put in the work, they do what it takes. They don't try and hack biology, right? They know that to respect the way that the body actually requires the time that it needs in order to do what it is that it needs to do, right? That are typically, by far, the happy experiences. The so sad experiences are the ones where people come to me, they have a conversation today, then they go away, they do a whole lot of disjointed thing, come back to me 2 years later, or 3 or 4 or 5, right? Only to tell me, look, I've tried all of these extra things and I've spent thousands and thousands of dollars and I've spent years and I'm still not pregnant. Can you help me? That is a heartbreaking experience for me and for them, right? Because in some cases where they might be lucky, the answer may still be yes. But you know what? In many cases, the answer is no. And that always breaks my heart because, one, I feel like I haven't done enough to help them understand the importance of this. So I hope that today in this talk, I have done enough to help you understand the importance of addressing, looking at every single one of these categories, because otherwise you will fall into that bucket of the unhappy and very sad experiences that I have in my day-to-day, where I have to talk to people who no longer have the chance that they had when we first talked years before. Right? So don't be that person. Please, whatever you do, don't be that person. And if you are that person, hurry up and talk to my team, because we need to get this sorted, right? But really, that is the saddest thing that I see. So the reason that I mention these things, the reason that I bring this up is because it's so easy to just feel like, it's going to be fine. 1 month turns into 2 months, turns into 12 months, turns into 2 years, and we're still not there, but we kind of think that, we'll just keep hoping. Right? Don't keep hoping. Do the work. Put in the understanding that's required, the time, the energy, the money, the focus. Do it, because you will never regret having done it. You will never regret having clarity and having made a choice and having made a decision, right, in terms of your situation, but you will regret not having done what it took. If you get to the end of the line and go, okay, well, no longer, right? So just be really aware, because implantation failure and miscarriage, you don't want to keep going around in circles. That takes time. Every time that you have a miscarriage, guess what? It takes at least, by the time, so when a woman has a miscarriage, it takes 4 to 8 months to get her hormonal balance back in order. Just to get it back to normal so that she can start ovulating again and have the best possible chance of conception, right? Let alone actually for some women whose hormonal balance becomes so imbalanced that it takes much longer than that. But imagine let's say that it takes the minimum amount of time, which is around 4 months, to get your hormones back into order, right? So you can start trying again. Let's say it takes another 3 months for you to get pregnant. Okay, so that's 7 months. Let's say you're pregnant for another 3 months. So that's 10 months. And we're 10 months down the track, no further forward if we have a miscarriage at that point, because we haven't done this work, right? So just don't underestimate the importance of this and what I'm talking about. Educate yourself more. Get a copy of the book if you need to. Have a chat with my team, right? We do completely free assessments for couples to be able to understand first if we can help. The reason that our success rate is so high is because essentially we screen. for the cases that we believe that we can help. We specialize in very difficult and complex cases, and so we have to look and see, okay, well, have we seen this before? Can we do something about this? And if we can, great. If we can't, we give you some further information about what perhaps could be useful in your situation. But don't just let it be and think that you can just do it on your own, because you can't. You really can't. So if you want to have a chat with my team, go to thefertile.me/chat. That's thefertile.me/chat. And just book in a complimentary discussion. You have nothing to lose and everything to gain. So I hope this has given you some good insights in terms of places and areas to look at. It is complex. It's a very difficult field. There are many different variations. For every permutation that I see in my clinic, there are many, many more. And so what happens is that it's important to do your best and start to remove the obstacles to your optimum health and optimum fertility. If you do nothing else, start there, right? It's about starting the process with acting pregnant now to get pregnant and take home a healthy baby later, and adding to that, right? Adding this extra layer that can really help to transform the results that you've gotten up until now. So I hope that helps. I look forward to seeing you guys again next week. Next week, we're talking about male infertility. So that's going to be a great, great talk about all of the things that men can do to optimize their health, as well as their sperm health and their chances of taking home a healthy baby. So watch out for that, and I look forward to seeing you guys again next week. Bye for now.